So nice to meet you. This is Dr. Claire from Cognitive Sports Therapy. This is our time to talk this week. We're a day early, but it's Bipolar Awareness Day this week, and I wanted to get Dr. Cross on with me today for his Dr. Cross. And I go way back. I was dancing around oldest friend comment when I was writing the blurb about this today, but I think Sean's probably one of my oldest friends. Not age-wise, let's dance around that a wee bit more. But so Sean is a consultant psychiatrist based in London, works in the Maudsley, works King's College, and works NHS mostly, but does have some private practice as well in London. And these are only 15 minutes. It's our little kind of nugget about bipolar awareness, because we know statistically, it's affecting sort of 1% to 2%, they say, in the UK currently. But I think when I was doing the research for this week and just writing my little kind of social media post, the thing that struck me, Sean, was that they were saying that it takes nearly 9 years for someone to get a diagnosis. And it also strikes me that it's one of those diagnoses that in the world of Google, people walk into my clinic often and say to me, I think I might have bipolar. So I wondered that we could maybe have a bit of a chat just about symptoms, I guess. And because to me, bipolar type 1 is quite clear cut. You've got manic episodes, you've got depression. But bipolar type 2 is a little bit more subtle. I don't know what you would say about that.
Yeah, absolutely. And so I think one of the biggest things that people seek help for at the moment is mood fluctuation. And it's something that many of us struggle with, in particular in the last year or two, with everything that we've all gone through, trying to work out what is normal mood response and what is a response that starts to push towards struggling or even illness, is something that people reach out for all the time. And so I think one of the reasons that it takes a long time to sometimes get a definitive diagnosis is because we're really not clear what's going on. And like many mental health disorders, what we don't have is, a blood test, a scan, something that gives you a definitive diagnosis. What we're basing our diagnostic intervention on is, what someone is saying. So you need to witness this, and you need to take someone's careful history. And so, all of us have experience of mood going up a little bit and mood going down a bit. Many of us, somewhere between a quarter and a third of us will experience depression, by far and away the most common mental health disorder out there. But a much smaller proportion of those people will also experience mood getting up into what we call hypomania or even mania. And these are the symptoms that are the real markers of a diagnosis of bipolar. But increasingly over the last few years, people start to think about bipolar as being much more of a spectrum. We talk about bipolar 1, we talk about bipolar 2, but increasingly these things don't exist in a vacuum. People also experience stuff that doesn't quite meet criteria for bipolar 2 either. And so there's often a sort of a necessary repeat questioning and repeat investigation for the kind of mood fluctuation that someone is experiencing.
And do we still look for sort of sustained periods of mood to make that diagnosis? Is that still where we're at, or has that changed at all?
No, very much so. Particularly for bipolar 1, you need all these kind of drivers of an elated mood that don't just last for seconds or minutes or even hours, but they need to last for a prolonged period of time. So you're definitely looking at days to weeks. It usually doesn't take that long, because a lot of people, if it does become very obviously manic, can sometimes come into contact with services much sooner than necessarily weeks going by. But it's that sustained period, which is very different to someone having just this burst of excitement or this burst of energy that all of us will have experienced, and that we don't want to medicalize. It's very normal to experience this fluctuation. The challenge, I think, for mental health professionals and for everyone when we come to look at this is that, sometimes it's not just a question of saying, is it sustained or is it what might fall within sort of normal range, if you like, of experience. There's often a hinterland in between, and that's where diagnoses like bipolar 2, that's where things like borderline personality disorder, emotionally unstable personality disorder, other diagnoses like cyclothymia, really are used as an attempt to trying to create an explanatory model over someone's mood experiences. And this is often quite messy for people to experience, or patients to experience, because what you don't end up with is a definitive yes, you have this, or no, you don't.
Yeah. And I think it is quite useful to kind of say that thing around what mania actually is, because I think people do have that expectation that if you're manic, that you are full of energy and that you're feeling really creative and you're as happy as anything. And actually, the reality is often very far from that, because if you see anyone who is acutely manic, often they are not happy people, or they're really quite disturbed people. And I think it's worth knowing that.
Absolutely. So mania or manicness is one of those words that's just entered, our vocabulary. It's used very colloquially. I was having a bit of a manic day. I was running around in a very sort of manic way. So it's the kind of stuff that many of us would use just to describe busyness or kind of a sense of being overwhelmed. And that's not what mania is. If we think of sort of normal mood distribution and then move through hypermania to mania, then when someone is experiencing mania, then it's the symptoms that people have are really quite marked. It's not just this sustained period of being elated in mood, but all the other stuff that is often associated with it. So people being sort of getting by and functioning, or feeling hyper energized when they're getting very, very little sleep, maybe no sleep or 1 to 2 hours sleep per night consistently for a long period of time, but still feeling as though they have that inner motor and can keep going. Speech is often very fast and sometimes very difficult to understand or comprehend. In addition, the thought processes that people experience, both in how they think, the process, but also in the content of what they think, can be markedly impacted. So we talk about thought disorder, where someone shoots around, moving from topic to topic with no obvious sort of logical or coherent link, and in the kind of content that people experience, this is a reflection of what we're talking about, being high. So the kind of thoughts that people have tend to be very grandiose. People think I'm the king or queen of the world. I'm the richest person in the world. I'm the most amazing person in the world. Much of which is quite lovely to hear, but is often rooted in a delusional structure where there's lots of evidence that is not true, but the person themselves believes it. So this whole constellation of stuff together becomes highly challenging and very, very problematic for individuals. I've got a number of patients who've described that sort of uptick in mood, where they sort of say, if you could just bottle that as you just start to kind of head up,
the beginning,
then that would be an absolutely wonderful way to live life permanently. The difficulty is that the vast majority of people don't live in that slightly elated, slightly upticked way as far as their mood is concerned. What happens is it shoots up. And then and as soon as it shoots up and starts to, we start to have all the symptoms that I was describing a couple of minutes ago, then dysfunction occurs. Dysfunction in relationships, dysfunction in work life, dysfunction in financial situations, and huge amounts of damage can actually occur for people, and that then needs to be addressed at some point when sort of mood comes down. The wheels come off in people's lives, and that can take weeks or even months to sort of rebalance and rectify, which is why it's really quite pernicious when one of these manic episodes kicks in.
It's that thing that insight goes, doesn't it? So that kind of ability to see the reality. And I think that's the point that it becomes really difficult then. It's very hard to treat someone, I think, sometimes with bipolar, because that delusion, as you say, is so strong, and that they've lost that ability to see what is real and what is not real. It's difficult.
Absolutely. So we're talking about, many of the things that I started to talk about earlier, about how nice it would be to think, wonderful things, to feel energized and to feel creative and to have lots of, amazingly sort of creative thought processes that go on, to see patterns where people don't see patterns, which is the reason why there's such a link between bipolar and the creative arts and creativity in general. There are many comedians, writers, artists throughout history who have either definitely struggled with bipolar or who probably struggled with bipolar, because it's a relatively modern concept.
Yeah.
But the difficulty is when someone does get into that state of not being able to understand what's going on and insight disappears, then of course it's really difficult to engage with someone and say, what I want you to do is to take this medication, or to be over here where actually what we're doing is going to take away all this stuff.
Yeah.
And actually, we're going to give you medication that could potentially also give you a whole range of side effects, because we don't have beautifully targeted medication that simply get rid of the mania and allows someone to restabilize. Many of the medications that we use tend to have a range of side effects, like weight gain, like the ability or like the ability of the ability to damage a whole variety of organs, like your kidneys or your thyroid or other stuff. So there's no doubt at all that the problem that the medical profession has around managing this stuff is that we don't come with an amazing array of interventions that is going to be the most helpful at all.
So that's what I think that was leading on to what I was going to sort of just ask about it as well, is just that I do then see people who have been well, but they really don't like the medication. And I guess maybe have forgotten that the not nice bit of being manic or being depressed, and stop taking their medication. And I guess one of the things I was hoping we could put across here is, if anyone's struggling and doesn't like the side effects, then it's worth coming and having a chat. Because I mean, it feels like there might be more medications coming that have got better side effects. I mean, we still use the older drugs, don't we? But newer drugs coming.
Still very much the drugs that we tend to use are things like mood stabilizers. Lithium is the obvious big one, but many of the anticonvulsants that are also used to treat epilepsy also have very good evidence base, so things like sodium valproate or carbamazepine or lamotrigine. But also we use anti-psychosis medications. So things like olanzapine and quetiapine are also very good at helping sort of stabilize mood. But all of these come with an array of potential side effects. And so what you really want is a doctor, a medical team, a psychiatric team to work with you, because I can understand completely. If I was struggling with bipolar, the thing I'd really want to do is not take the medication every day.
Yeah.
But there then becomes a sort of balance between how do I take enough medication to try and keep me well for some stability over the medium term, so I can get on with my life and have a relationship and a family and a job and stability, versus having to put up with an array of side effects that are really problematic. And there's a ton of research around trying to work out how much of a sort of minimum intervention we need for a shorter period of time as possible. But, guidelines and regulations change around this fairly frequently, but it's really all about trying to tailor it to an individual person's previous experience.
Yeah. And I think that you touched a little bit there on kind of, I guess, the last thing that I hope we would talk about is just that it does need medical input. So, I do these sort of talks a lot, and a lot of the stuff I talk about is lifestyle medicine and that kind of thing. But bipolar disorder really does need medical input. And I think certainly I've come across situations where friends and family have tried their hardest with someone who's been unwell and really just not really known what to do. And I think it's worth just sort of saying here, I think, isn't it, that it's the sooner you get input, the better. And if you see someone becoming unwell, that, try and get them in contact with medical staff as soon as possible.
Absolutely, 100%. There are many kinds of mental health struggles that all of us have. That many well-being initiatives, well-being interventions are really, really important. But when I always think of, you want everyone to be thriving, then people move through struggling and then into illness. When someone has a full-blown manic episode, they're very much at the illness end of the spectrum. And it's really important to try and minimize it for the shortest time possible, that, doctors, medical teams are actually involved, hopefully tailored to something that works for that person and that individual for sure. But it's really important that medical advice is sought.
Yeah. And I mean, I've had recent scenarios where I've had to encourage people to call the police to really help individuals because they've not got the insight to go and even get that help themselves. And people have felt uncomfortable doing that to friends and family, but actually that it's not a calling the police to get someone into trouble. It's calling the police because they are in the UK, certainly the safest way to get someone into a place of safety, which is what we want to do if they're unwell.
Absolutely. So, you know, there's no doubt at all that it's a failure if police have to be involved, because
Yeah.
we don't want police involved near any of my friends or family. But sometimes it's the only way of trying to contain things and keep things safe. What we really want to do is get a care plan tailored to that individual that never involves
Stops it happening.
at all.
Yeah, definitely. This has been great. Sean, as I say, I try and limit it to 15 minutes. We could obviously talk about this for ages. I always say to people, I'm happy to be asked questions afterwards. So I'm sure that you're happy for me to send some your way if I can't answer them.
Absolutely.
But thanks for coming on. And I look forward to seeing everybody next week for time to talk, back to Wednesday next week. Thanks.
Thank you very much.
Bye, Sean.